Hi, I'm Dr. Kim Keebler, and this presentation is Palliative Practices for Patients Living with Multiple Chronic Conditions. As a disclaimer, I am the director and founder of the virtual Multiple Chronic Conditions Resource Center, providing evidence-based practice on the chronic conditions and symptoms for interdisciplinary healthcare professionals, as well as patient and family education. I'm the president of Advanced Disease Concepts and editor and author of the American Nurses Award-winning Integration of Palliative Care and Chronic Conditions and Interdisciplinary Approach. The objectives for this presentation will examine the demographics and social burden associated with the largest, fastest, and costliest U.S. patient population, those living with and dying from multiple chronic conditions. A review of current global initiatives influencing the clinical care of patients with multiple chronic conditions. Will describe common chronic conditions and associated symptomatology, as well as discuss the role of palliative care as aggressive symptom management in patients with multiple chronic conditions, and the role of the nurse in effective use and implementation of palliative practices in patients with multiple chronic conditions. If we look at the changes in demographics across the world, we're not as young as we used to be. And globally, the population age 65 and older is growing faster than all other age groups. Population aging is poised to become one of the most significant social transformations of the 21st century, with implications for nearly all sectors of society. The United Nations identified in 2019 that by 2050, 1 in 6 people in the world will be over age 65. That is 16% of the world's population, up from 1 in 11 in 2019, or 9% of the population. The World Health Organization this year identified that between 2015 and 2050, the world's population over 60 years of age will nearly double from 12 to 22%. And by 2020, which is this year, the number of people aged 60 and older have outnumbered children younger than 5 years. In 2050, 80% of older people will be living in low and middle income countries. And the pace of the population aging is much faster than it has been in the past. All countries face major challenges to ensure health and social systems are ready to make the most of this demographic shift. If we look at this graph, you can see that children under 5 are decreasing in the world as adults 65 and older are increasing. This will have profound effects on caregiver support in the aging population, as well as financial resources to manage this patient population. This simple graph looks at the global life expectancy from 1900 to 2100, which has increased substantially. And we are living longer as a result of better medications, better diagnoses, understanding diseases and their management. The Centers for Disease Control and Prevention in 2017 and the World Health Organization in 2019 announced that globally, we cannot effectively address escalating healthcare costs without addressing the problem of chronic diseases. A chronic condition is a physical or mental illness that lasts more than 1 year, often causes functional restrictions, and requires ongoing monitoring and treatment. Multiple chronic conditions are more than 2 concomitant conditions together, such as diabetes, hypertension, hyperlipidemia, hypothyroid, obesity, depression, arthritis, etc. The World Economic Forum this year identified that 1 in 3 adults worldwide have more than 2 chronic conditions, and that the complications and costs of treating multiple chronic conditions double with each additional condition, and are 16 times costlier to treat a patient with 4 conditions versus 1. The costs and complications grow exponentially, limiting mobility, increasing pain and fatigue, and making it difficult to work. Multiple chronic conditions require excessive medication use, often causing side effects and reducing quality of life. Adhering to complicated drug regimens also becomes a challenge in managing this patient population. As the number of chronic conditions increase, so does the effects of increased morbidity and mortality, cost of care, increased hospitalization, confusing or conflicting advice from multiple providers, and the use of 8 or more concomitant medications, contributing to polypharmacy and other associated symptoms. Patients with multiple chronic conditions experience poor day-to-day functioning, contributing to deconditioning, frailty, and disability. The decline in functional status contributes to limited access to healthcare and inability to self-manage, and creates an untoward reliance on caregiver support and demand and a poor quality of life. This graph comes from the Centers of Medicare and Medicaid looking at beneficiaries in 2017, and the reason for placing it in this presentation is to show, and it's hard probably to see all of the conditions that are identified on the left hand, but to note that majority of these patients have 5 or more conditions at any given time. In the United States, in 2010, we passed the Affordable Care Act, and the reason I wanted to present that today is that a major influence of the Affordable Care Act is focused on the prevention of chronic disease and improving public health. And there are multiple agencies within the U.S. Department of Health and Human Services that are focused specifically on aspects of multiple chronic conditions. If we look at disease trajectory and how that influences our clinical decision-making, for patients who have cancer, it's pretty predictable. Patients are functional, and as the disease progresses, they become less functional and more symptomatic and leading to death. But if we look at patients with heart failure or COPD, this changes over time. Patients go into hospital with an exacerbation, and each time they go into a hospital, their prognosis is worse, and eventually leading to death. Patients with Alzheimer's and dementia have an insidious decline that eventually will lead to death over time. Palliative care is the science and practice of symptom management. It is through a team-based approach that this is carried out and should not be reserved only for the last 6 months of life. There is a lot of confusion between palliative care and hospice care, and both of these are very different in their approach and in their implementation of care. Multiple chronic conditions produce accompanying symptoms, and poorly managed symptoms contribute to disease exacerbations, debility, and frequent hospitalizations. The use and implementation of palliative care promotes optimal quality of life, improves physical functioning, and reduces costly care. If we look at heart failure for an example, when patients are often referred into a palliative care service, their heart disease is at a New York Heart Association stage 3 or 4. But if you look at stage 2, 64% of these patients have sudden death, and the use of palliative care in this patient population would prevent that patient from being symptomatic and entering into hospital frequently with exacerbation. We look at common symptoms associated with heart failure. They include dyspnea, edema, decreased exercise tolerance, depression, insomnia, anxiety, agitation, angina, generalized pain, cachexia, fatigue, and I'm sure that there are some symptoms that you can identify that are not included here. But the amount of symptoms that are associated with one given condition actually determine how well that patient is managed and their quality of life. COPD is another example where patients who have exacerbations have a cyclic effect of breathlessness, inactivity, reduced exercise capacity, deconditioning, and eventually this leads to poor quality of life and eventual death. Palliative care interventions should accompany routine medical management from the initial diagnosis of a chronic condition. And as the disease increases, so does the intensity of palliative care. And this does not require different providers or specialty. This should be performed within the primary care setting. Let's look at JH. He's a 72-year-old Caucasian male with a 48-pack year history of smoking. He has an FEV1 forced expiratory volume of less than 65% predicted, confirming the gold stage COPD, gold meaning the Global Initiative of Obstructive Lung Disease. He has a body mass index of 42, confirming morbid obesity with a confirmed diagnosis of congestive heart failure with an ejection fraction of 35. He was diagnosed with type 2 diabetes from a recent hemoglobin A1C of 8.1. He presents to the clinic today with complaints of dyspnea, cough, purulent mucus, fatigue, insomnia. He's febrile and is exercise intolerant. As the nurse managing this patient, what is the primary objective? Preventing an exacerbation of his COPD and CHF, preventing him from going into hospital and having his disease progress. Why would this comprehensive routine disease management require specialty? In this patient population, we need to be coordinated, provide comprehensive, cost-effective care. These citations are from the research that I have performed on undergraduate, graduate, and graduate clinical faculty. All of these research studies have the same design. The students and the faculty were first asked to self-report their knowledge on common chronic conditions, associated symptoms, and their management, and then they were tested from actual knowledge examination, objective knowledge examination based on current guideline recommendations. The mean scores from the self-perceived knowledge and chronic conditions, the undergraduate students were looked at from the Southeast United States and the Northeast United States. And what's interesting is the red shows they're least knowledgeable and the blue shows they're knowledgeable. Almost all of the cohorts had the same scores and the same understanding of diseases, with diabetes being the most knowledgeable, cancer, end-stage renal disease, and HIV as being the least knowledgeable. For the mean score of self-perceived knowledge, diagnosis was the least, which is concerning for me and graduate students, particularly graduate nursing students and graduate clinical faculty. Who are being trained to manage patients. Diagnosing and treating these patients are key to ensuring good care. Referral was the least knowledgeable in undergraduate students, and assessment was the most knowledgeable. As far as conditions or symptoms go, again, I'm concerned about the inability to recognize the differentiation between non-malignant pain and malignant pain. These are managed similarly, dyspnea being most knowledgeable and cachexia being least knowledgeable. Overall, for the objective assessment examination, undergraduate nursing students scored 50% out of 100. This was, again, the 46-item objective knowledge examination. Graduate nurses scored 70%, and we know that a passing grade is at least an 80%. And the clinical graduate nursing faculty scored 14%. And these tests, the first test was in 2 cohorts. It was a pilot study for the undergraduate students at 2 BSN programs, and the graduate nurses and faculty were targeting 800 nursing programs in the United States. Least knowledgeable were heart failure, COPD, end-stage renal disease, non-malignant pain, and malignant pain, differentiating somatic pain from neuropathic pain, cancer, and cachexia. These findings highlight negative issues regarding the development of advanced skill set required of the nursing profession as the tsunami of the world's aging population living with multiple chronic conditions continues to rise. So what do we do if not to make life better for others?